Good morning, everybody. Our lecture for today is the imaging of small bowel tumors. These are the main outline of the lecture. First, the introduction, and then the malignant tumors, the most common types of primary, and then the metastasis, and then some short notes about the benign tumors and some possible mimics. صوت واضح صوت زين
واضح.
First, the introduction. Small bowel tumors in general are rare. They account for only 3 to 6% of all GI tumors. The clinical presentation is non-specific. The symptoms include abdominal pain, anemia, GI bleeding, and bowel obstruction. The diagnosis is challenging because, as I mentioned, they are rare, and the clinical presentation is not specific. They require high index of suspicion. The types of tumor, in general, they are divided into malignant and benign. The malignant tumors are divided into primary and metastasis. The most frequent primary tumors are those 4 types: the adenocarcinoma, which is the most common type, and constitute about 30 to 40% of all primary tumors. And the carcinoid, it is the second most common, 25 to 30. Then the lymphoma, 20%, and just gastrointestinal stromal tumors, 10%. The metastasis, in general, the metastatic tumors are more common than primary tumors. And the most frequent metastasis is the melanoma, and then followed lung, breast, GI, and ovaries. The benign tumors, in general, are rare. The most frequent benign tumors are the leiomyoma, adenoma, lipoma, and hemangioma. This image shows the distribution of primary malignant tumors in each part of the small bowel. We can see that in the duodenum, the most frequent type is the adenocarcinoma, and the incidence decrease as we move distally. It is rare in the ileum. يعني عكس الcarcinoid. الcarcinoid more common in the ileum and less common in the duodenum and the jejunum. And this pie chart shows the distribution in all parts of the small bowel. As I mentioned in the previous slide, the adenocarcinoma is the most common type, and followed by the carcinoid, then the lymphoma, and just. The imaging modalities, endoscopy, ultrasound, and the biome study are usually the first-line study for all non-specific clinical GI symptoms. We also have CT and MR intrography and interclysis. Both have good performance in the diagnosis of small bowel tumors. The choice mainly depends on personal preferences. Regarding MR intrography and interclysis, the contrast media is usually either water or methylcellulose, which appears low signal on T1 and high signal on T2. The luminal distension should be at least 2 centimeters. The normal wall thickness of the small bowel is up to 3 millimeters. Apart than that, should be considered abnormal. Collapsed small bowel can be easily misinterpreted as thickening or abnormal enhancement. So as I mentioned, it should be distended at least 2 cm. The resolution in MR is generally less than the CT, so lesions less than 5 millimeters uh, may be missed by MRI and better seen by CT. CT angiography is useful in demonstration of the site of bleeding in case this patient is presented with GI bleeding. Endoscopic ultrasonography is sensitive in the evaluation of the periampullary tumors. The PET scan is useful in staging, but it is not the first choice in assessment of the primary lesion. We also have the capsule endoscopy, which also may play a role in the workup of the small bowel tumors. This is video capsule endoscopy. Its main limitation is the inability to make intervention and inability to take biopsy. First, we start with the adenocarcinoma. It makes 8% of all GI neoplasm, 30 to 40% of small bowel neoplasm. The mean age is 60. Slightly more common in male than female. The prognosis is generally rare. The 5-year survival is 15 to 30%. The resectable tumor are generally non-survivable, while the resectable may have a 40 to 60% 5-year survival. And these are the risk factors. The hereditary non-polyposis colorectal cancer and familial familial adenomatous polyposis, Pers-Jaeger, celiac disease, and Crohn's disease. The imaging techniques. We have CT intrography, interclasses, and MR intergraphy and interclasses. The difference between interclasses and intergraphy is that the intergraphy, the contrast is introduced directly to the small bowel by NG tube, so it results in more distension, but it is more invasive. While in intergraphy, the patient drinks the contrast. So it is non-invasive, but it results in less bowel distension. And these are the sensitivity and specificity numbers for CT interclasses, CT and MR intergraphy. The specificity of all these modalities are high, are very high, but the sensitivity slightly varies. It is more in the CT interclasses and MR intergraphy. But in general, the intergraphy, whether CT or MR, it's preferred over the interclasses because it is non-invasive. While the sensitivity numbers are acceptable. And this is the distribution of small bowel adenocarcinoma. It is more common in the duodenum, 60%, followed by the jejunum, 25 to 30, then the ileum, 10 to 15%. The typical imaging appearance of small bowel adenocarcinoma is focal, molecular circumferential mass with the shouldering and obstruction. Less frequently, it may present with intraluminal polypoidal mass. Ulceration is also a common feature. Extraluminal infiltration may present with a fat stranding. The enhancement is moderate, unlike carcinoid, which shows bright enhancement. Metastasis to the liver and the peritoneum may occur. Large adenocarcinoma may mimic just or lymphoma. This is the best imaging tool is the interclasses with the multiplanar reformation. This is the TN of small bowel of small bowel adenocarcinoma. It is. I don't think it is important in imaging, especially the T staging, because it is difficult to determine exactly the depth of the tumor. This is a case of small bowel adenocarcinoma presented with the circumferential thickening in the proximal jejunum, resulting in luminal obstruction and proximal dilatation of jejunum and stomach. Another case of an elderly man presented with weight loss and early satiety. The CT scan shows a circumferential thickening in the second part of the jejunum with luminal obstruction and multiple adjacent large lymph nodes and mesenteric fat stranding. This is the biome study of the same patient, obstruction of the second part of the jejunum and proximal dilatation. The case of ileal adenocarcinoma presented with circumferential mass with high-grade obstruction. The mass shows shouldering and mucosal ulcerations. And also there's proximal dilatation. This is another case, jejunal adenocarcinoma, presented with the nodular filling defects with mucosal ulceration, luminal obstruction, and proximal dilatation. This is a case of jejunal adenocarcinoma. The head of pancreas is not separable from the mass in this case. So sometimes this tumor is called called periampullary tumor because sometimes the exact origin of the tumor cannot be determined. It could be jejunal adenocarcinoma or pancreatic head adenocarcinoma, distal CBD cholangiocarcinoma, or ampullary vater tumor. This is a case of 60-year-old man with weight loss and early satiety. The contrast enhanced CT shows multiple liver metastases and large peritoneal lymph nodes. This is the same patient. The CT scan shows a circumferential thickening in the third part of the duodenum with the luminal obstruction and proximal dilatation. This is the follow-through of the same patient. It also shows a transition zone in the third part of the duodenum due to high-grade obstruction and proximal dilatation. This is another case of jejunal jejunal carcinoma. This case also a adenocarcinoma in the jejunum presented with a large mouth with annular thickening, aneurysmal dilatation of the bowel. This case may mimic lymphoma. This is another case of ileal adenocarcinoma presented with bowel wall thickening. The differential diagnosis here is Crohn's disease, but this patient does not have a history of Crohn's disease, and the terminal ileum is normal. It is not shown here in this picture. At surgery, this proved to be an adenocarcinoma. This is an MR imaging of a jejunal adenocarcinoma in the distal duodenum. This is also an MR study, post-contrast T1 with Fastat and T2 shows a circumferential thickening in the jejunum with the luminal obstruction and dilatation. The differential diagnosis, lymphoma. Lymphoma عادة so narrowing without obstruction, and aneurysmal bowel dilatation at the tumor site, or large mesenteric lymph nodes. It just is usually large exophytic mass with the central necrosis. Carcinoid more common بالإليوم or hypervascular. Mesenteric invasion with dysplastic reaction. Crohn's will seen in the distal ileum or long segment thickening or mucosal hyperenhancement and edema, skip lesion and fistula. But sometimes it is difficult to differentiate adenocarcinoma from Crohn's disease. The metastases are usually multiple, and the patient is already a known case of primary. Now the lymphoma. The risk factors are as listed: celiac disease, Crohn's, SLE, immunocompromised state, history of chemotherapy, and intestinal lymphoma. The imaging features. The most common morphology of primary tumor is the infiltrative lymphoma. It is the most common. Present with the circumferential mass, sausage shape, with aneurysmal bowel dilatation, as I said earlier, without causing obstruction. The aneurysmal dilatation is occurred due to destruction of the bowel wall and myenteric nerve plexus. The other two presentations are rare. They are the polypoidal lymphoma, intraluminal mass with bullseye or target lesion, and endo-exoenteric. This form is rare. It presents with a large cavitary mass, a transmural extending through the wall of the bowel, which will result in perforation and fistula formation. The other supporting features are lymphadenopathy, mesenteric and hepatoperitoneal, and hepatosplenomegaly. The imaging features. The best imaging tool is the CT Intrography with multiplannar information, as with any other small bowel tumors. The fluoroscopic guided interclass may be benefit and useful in the demonstration of the mucosal and the subtle intramural disease. This case is of small bowel lymphoma presented with the multiple circumferential thickening of the wall of uh, a small bowel and multiple adjacent large lymph node. This is another case, multifocal thickening in the wall, luminal narrowing, but without abstraction. And also there's multiple large mesenteric lymph nodes. The differential diagnosis, the same as with any small bowel tumors. For the small bowel adenocarcinoma, as we said, it is likely to cause obstruction and less likely to cause dilatation. And the nodal metastasis is usually smaller than the lymphoma. Just a large exophytic mass with the central necrosis. The carcinoid, as we said, more common in ileum, hypervascular mesenteric invasion with dysplastic reaction. And Crohn's and the small bowel metastasis. And now the carcinoid tumor. It is rare. It is 2% of all GI tumors and can be divided into well-differentiated, known as carcinoid, and poorly differentiated, known as small or large cell neuroendocrine carcinoma. It's common in the 5th or 6th decade, more common in male. The prognosis are generally good in patients without liver or nodal metastasis. The 5-year survival is 90%. And in those with metastasis, 50%. The imaging features. Most common site is the appendix, but the appendiceal carcinoma in the appendix is usually detected by after surgery on histopathology. Well, the most common type detected on imaging is the small bowel carcinoid, which constitute 33% of GI carcinoid. The most common site is the ileum, and it is rare in the jejunum or duodenum, and the stomach is also rare. 1/3 are multiple. Metastasis occur at the liver and lymph nodes, followed by lung and bones. The metastasis depends on the tumor size. The larger the lesion, the more likely the incidence of metastasis, and also on the tumor site. Ileal carcinoid are more likely to metastasize. The incidence of metastasis is 38%, while the appendiceal carcinoid are rare to metastasize. 3% risk. Liver metastases are nearly always hypervascular and enhanced on the arterial face. The carcinoid syndrome, it occurs in about 5% of carcinoid tumors, and it occurs due to vasoactive substance that enters the systemic circulation. It is associated with the liver metastasis, and the symptoms are flushing, diarrhea, bronchospasm. The imaging features. The typical imaging appearance is solitary enhancing distal ileal mass with mesenteric metastasis. The primary tumor is sometimes may be difficult to detect than metastatic foci. Mesenteric mass is either due to direct invasion or nodal metastasis. The calcification in mesenteric mass is common, up to 70%. And the mass may show speculation with the stellate pattern, tethering, fixation, retraction of a small bowel, encasement of the mesenteric vessels. Liver mets, as I mentioned, they show intense enhancement in the arterial face and wash out in the portal and delayed the faces. We have also the nuclear medicine findings. We have 3 types of study. Indium 111 octreotide or somatostatin scan, a scan, and we have the PET scan and iodine 131 MIBG scan. The most important and widely performed is the indium 111 octreotide scan. The best diagnostic clue is the mesenteric discrete enhancing mass with the calcification, plastic reaction, plus minus liver metastasis. The recommendation for imaging, multiplanar contrast enhanced CT or MR, arterial face and venous face, and also the scan or somatostatin scan maybe performed. This is a case of carcinoid tumor. This is hyper-enhancing ileal mass. The primary carcinoid, this one. And this one, the mesenteric metastasis. Also hyper-enhancing with the tethering of the mesenteric due to plastic reaction. This is a carcinoid metastasis present with the multiple hyper-enhancing liver lesion on the arterial face and wash out on the portal venous face. This is another case, a large hyper-enhancing mesenteric mass with the central calcification and engorgement of the mesenteric vessel and tethering of the mesentery. This is a metastatic carcinoid presented as multiple hyper-enhancing liver lesion and peritoneal deposits. This is a small bowel carcinoid presented as hyper-enhancing mural mass. The, the differential diagnosis, the most important is the sclerosing mesenteritis. The most important in this condition is the fat halo sign, which preservation of fat around mesenteric vessels. Unlike the carcinoid tumor, which this sign most likely not be seen. And we have also the just and small bowel adenocarcinoma. Metastasis and lymphoma also may be included in the differential diagnosis. The just it is mesenchymal tumor of GI derived from interstitial cell of Kajal. 10% of small bowel tumors, male equal to female, median age of 55, 20-30% are malignant at presentation. In stomach, they are more likely to be malignant. The tumor is usually grow extraluminally. I mentioned necrosis, calcification, hemorrhage, fistula formation. The distribution, most common in stomach, and second most common site is small bowel. In the duodenum and jejunum, more common than the ileum, 25 to 50% each. Its size varies from few millimeters to 30 centimeters. Just typically present as large exophytic mass with heterogeneous enhancement and clean delineation from the mesentery. A tumor less than 2 centimeters are usually benign, while those larger than 5 are often malignant. Intraluminal mass is less common. Obstruction is rare because the tumor is not intraluminal. It grows extraluminally. Unlike carcinoid, as we said, the primary lesion in carcinoid is more often small and sometimes difficult to detect, while in just the primary tumor is large and easily seen. Both just and the lymphoma can show aneurysmal dilatation of the bowel. Liver metastasis is usually hypervascular and may be missed on a single portal face CT. شغلة مهمة هنا lymph node metastasis are generally not seen. If lymphadenopathy is seen, we should consider another diagnosis. Mesenteric and aortic metastasis more common in recurrent disease than the first presentation. After chemotherapy, the liver and mesenteric metastasis may become hypovascular or even cystic. Recurrent rate after surgery is 40 to 90%. The best imaging tool, contrast enhanced CT with multiple information and all contrast. Best imaging tool for staging is the PET CT. This case of ileal just presented with a large exophytic heterogeneous mass from the ileum. This case is recurrent just. On the recurrence, as I mentioned, it usually occurs as metastatic disease in the liver or the peritoneum. This is a multiple liver secondaries and a large peritoneal deposit. This patient is an elderly man presented with upper abdominal discomfort, and the CT scan shows large irregular heterogeneous mass in the upper abdomen related to the second part of the duodenum, and the mass shows areas of necrosis and calcification. It is proved to be just. Differential diagnosis: lymphoma, bulky mass, sandwich sign, retroperitoneal lymphadenopathy. Lymphadenopathy قلنا just ما نشوف lymphadenopathy. الكارسينويد, metastasis, multiple lesion or non the metastasis. The metastasis is more common than the primary tumors. The melanoma is the most common primary site, present with enhancing masses within small bowel mesentery or bowel wall, and the target or bullseye signs sometimes seen. Lung and breast carcinoma. Usually present as serous tumors, which mean they exert fibrotic reaction and may cause luminal obstruction. GI and ovarian tumor. They usually spread transperitoneally to the small bowel serosa. May result in adhesions, fixation, and functional small bowel obstruction. Direct invasion also may occur from pancreatic head cancer or gynecological cancer, like uterine, cervical, or ovarian. This case is a metastatic melanoma present with multiple mural and intraluminal masses in the stomach and small bowel, and also there are multiple peritoneal deposits, and also a renal metastasis. This is another case of metastasis of melanoma. The patient presented with weight loss and diarrhea, and there are large multifocal masses in the small bowel. This is a case of a small bowel metastasis with unknown primary. Also presented with multifocal small bowel masses. This patient is a known case of breast cancer presented with metastasis to the third part of the duodenum. And the lesion is annular, ulcerating, and extension to the external extension and causing luminal obstruction with the proximal dilatation. And now some short notes about the benign tumors. We have four benign tumors should be mentioned: the adenoma, lymphoma, leiomyoma, and meningioma. The adenoma is precancerous usually, and and sometimes seen in syndromic conditions such as familial adenomatous polyposis. The lipoma is the most distinct among all these tumors because it can be easily recognized by CT or MR as low attenuation mass on CT and low attenuation mass or low intensity mass on fat-sat MRI. The leiomyoma is sometimes considered a type of just and benign just sometimes considered a and others and sometimes it's considered as a separate entity. The benign features include the sharp margins, homogeneous aspect, and homogeneous enhancement. The hemangioma is not that important, but it's worth to mention that it is most common in the jejunum. This is a case of jejunal lipoma. It appears as a low density lesion on CT and low intense low signal mass on fat-sat MR. On endoscopy, it appears as a yellowish mass. These are some possible mimics of small bowel tumors. The sclerosing mesenteritis, also known as mesenteric panicolitis. The most important feature of this condition is the fat halo sign, as I mentioned. And also we have the desmoid. It is a rare tumor. It is not related to the small bowel. Rather, it is arises from the mesentery. It may be associated with the Gardner syndrome or previous trauma or surgery. And Crohn's disease also may mimic some small bowel tumors. The distinguishing features are the ulceration, but not definitive but these features are not definite in differentiation of Crohn's disease from malignancy. And in many cases, histopathology is needed to differentiate. But the features are the ulceration, increased mesenteric vessels comb sign, skip lesions, and increase in the surrounding fat. In this case of sclerosing mesenteritis, احنا الفات هالو sign this one preservation of fat around mesenteric vessels. هنا مو ممكن نشوفها الفات هالو sign. This is a desmoid tumor. This is Crohn's disease. الكوم ساين هاي هنا نشوفه. target sign. Target sign is usually a benign sign. When we see it, we should think of some benign pathology like ischemia, radiation, inflammation. الفات sign target sign عبارة عن mucosal edema, appear hypodense, are surrounded by enhancing mucosa and enhancing muscularis layer. In this case of enterocolitis, target sign is very clear here, and this case is bowel ischemia. Also, you can see target sign here. And thank you.